Thank you for coming. As part of the Health at Google Speaker Series, Dr. Meunnig is here today to discuss social networks and community reengineering, and specifically how to create health through information and policy. Dr. Meunnig is an assistant professor of health policy and management at Columbia University. He oversees over 2 million in research grants and has published over 55 original research studies in venues such as the New England Journal of Medicine, JAMA, and the American Journal of Public Health. His work has appeared multiple times in the New York Times, National Public Radio, and televised media outlets such as CNN. And so with that, I'll hand it to Peter.
Hello, everybody. So I am just getting off the airplane from China. I'm a little bit bassy, bear with me. So I'm going to go through this, and then we'll have some time for questions at the end. And if you feel something that's really burning, you can feel free to dig in. So what I'm going to be talking about today is the state of our nation's health and how we might fix it. So America's in really bad shape. And a lot of people think about this, about the health problems in this country is relating to the health system. And today, hopefully, I'm going to show you that it's not really a health system problem, although the health system is contributing to quality of life issues in this country, but rather the way that we've basically structured our society and the way that we think about addressing disease and preventing disease needs to be completely rethought. So I'm going to sort of give you a framework for doing that. Now, the tired old adage is, we're scientists, we have to sound scientific. And a gram of prevention is a kilogram of worth a kilogram of treatment or something like that. So everybody talks about prevention, and prevention is a way to address disease in this context or in any context. Like, who wants to get sick? Who wants to get cancer, even if there's a cure for cancer, right? So we want to prevent disease before it occurs. Fine. But it's not exactly that easy, right? You can talk until you're blue in the face about, we need to diet, and you need to exercise, and you need to stop smoking. But people don't like to be told what to do. And so just providing this information isn't really going to change anybody's behavior. In fact, even when your doctor tells you, hey, look, you really need to stop smoking, only about 1 to 3% of the patients will actually even try to stop smoking. So we need to actually come up with an entirely new framework for thinking about how we prevent disease. And that's going to be the topic of my talk today. Before I get into that, let's go back to the health system. Let me just outline the problems that we're facing here. Okay, so we don't have a graphic here? It's coming up on my screen. There we go. Okay, oops. This is 2005. We're not getting the previous graphic. Okay, anyways. Okay, we're having slight technical problems. So, in 1975, let me go back to that, even though you can't see it. In 1975, imagine. In 1975, the United States ranked more or less with the rest of industrialized nations. The life expectancy, it was at the back of the pack, but it was right in there, like in the top 10. And costs for healthcare were also in the back of the pack in terms of being a little bit high, but they were still a little bit lower than Switzerland's, for instance. So, one framework for thinking about this is, let's just pick a group. So, 45-year-old females. Let's look at 15-year survival. So, 15-year survival basically tells us, okay, well, what are your chances of making it over the next 15 years? And I'm just picking one select group because it's easier to think about things using one sort of case study. So in 1975, females ranked about ninth in terms of life expectancy of all nations in the world for which we had life expectancy data, and healthcare costs in the United States were second highest in the world. Now, between 1975 and the present, we would expect healthcare costs in the United States to increase relative to other countries. And the reason we would expect that is because other countries have national health insurance. And because the government is paying for everybody's healthcare universally, they have to contain costs. You see, the issue with health insurance costs is that they inflate much faster than the regular rate of inflation. So, healthcare costs are going up at 8% per year, inflation's going up at 3% per year. It's really easy for costs to get out of control. So all these other nations with national health insurance programs ration care. And they ration it based on, this is most cost effective. But what that ultimately means is that the people that live within those nations are not getting access to the most high-tech, most expensive medical care. It's just a fact of life. If there's a $100,000 new cancer prevention agent, you're not going to get it unless you can pay for it out of pocket and you live in one of those nations, right? So Americans are getting access to the highest tech care. Not everybody is, right? We have an uninsured population. We ration based on ability to pay, but we are getting access to the highest tech care, right? So based on that, we might expect higher costs in the US, right? But we would also expect that we would have gotten something for it. Here's 2005. Here's the United States. On this axis, this is per capita healthcare spending. This is what I would have shown you on the 1975 graph, but we don't have it. And this is the percent surviving 15 years. So in the United States, a 45-year-old woman's chance of making it 15 years is pretty good, 94%. But it is way behind the pack in terms of other wealthy Western nations and Japan in terms of 15-year survival. And one of the things that's really striking here is that the costs are twice as high as these countries, right? That I said we would expect, but the survival is much, much further behind. In fact, every year the United States loses ground to all of these other countries. And we're not just losing ground to all of these other countries, we're also losing ground to industrializing nations. Costa Rica is ahead of us now. Chile is ahead of us now. In fact, we've fallen to 49th place in terms of life expectancy worldwide. That's kind of sad. So something is going on. There's something about the United States that's making us less healthy. And the thing that most people would say was it would be like, well, maybe it is something else. Maybe life expectancy isn't the best indicator. What about health? Well, let's take a look at this. This is something I put together using a new data set that we just created at Columbia called the DSS-NDI. And it allows us to look at self-rated health status over time and mortality over time. And what we're seeing here is that the health of Americans, historically was increasing. You would expect it to increase. You would expect health over time to increase. It's just, we have better medicines and we have maybe a better diet. But in fact, it's not increasing. It plateaued sometime in the 1990s and it started to go down. And there are other quality of life indicators. So here's what's happening with all of those healthcare expenditures. This is what it's doing to our economic quality of life. So here, this is compensation after healthcare expenditures in thousands of 2006 US dollars, constant dollars, over time. And, you hear about real wages in this country. Real wages are increasing, right? Every year, real wages increase by, over historically by about 1% or something like that, meaning that our income is outstripping inflation. But if you subtract healthcare expenditures from that, then actually our real wages are going down. And they're going down because healthcare costs are going up so high, right? Remember in that last bit, we saw that healthcare costs had gone to twice that of any other nation. So the median income household is actually losing money over time because our healthcare costs are going up. And they're going up partly because we're spending so much money on medical technologies and things like that, but also partly just because we're getting sicker. So remember, we're just sticking with females in our case study example here. This is the time period between 1961 and 1983, and what you're looking at is, this is the United States of America. Not all Americans are good with geography. And these little blotches are counties within the country. And this is actually really concerning. What it is these little salmon patches indicate counties in which life expectancy did not improve. Now, life expectancy improves. We are evolving as a species. Every year, life expectancy improves for human beings. We're evolving genetically, and we're evolving socially. So, we're slowly kind of sort of tackling wars and nutrition problems, but we also tend to just evolve with mate selection and things like that. And as a result, life expectancy should just keep going up and up and up. In fact, if you look at Swedish female life expectancy, it's probably one of the most consistent biological phenomena ever recorded. It always increases by 1.3 years every 10 decades. It's just very consistent. Life expectancy is meant to increase. We only really see drops in life expectancy in extreme circumstances. So, for example, in the former Soviet Union, when there was a transition to capitalism, life expectancy plummeted. Sub-Saharan Africa with AIDS, life expectancy plummeted. These are very, 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 very big social events. Economic disruptions, war, infectious disease, outbreaks. We're not seeing any of that in the United States. I guess we get a little bit of economic disruption lately, but in general, nothing really, really big. This is the same map in the period 1983 to 1999. Now remember, these salmon areas are the ones showing that life expectancy did not change, and everybody was worried about that. Like, oh, there's some people who are not benefiting from increases in life expectancy in this nation. The red dots in this particular graph in the next time frame show areas where life expectancy actually declined for women. So what we're looking at for some counties, for some places in the United States, is a phenomena that you would expect only to occur in the context of a massive outbreak of disease, a massive economic disruption, something like that. Now, one of the things that's sort of striking about this pattern is that we see that it's mostly in this region of the country that we call the stroke belt. This is like, Rush Limbaugh territory. People going from their homes to their car, to their office, lots of car culture, lots of high-fat foods, things like that. We might expect that this is being driven by obesity, poor diet, things like that. Okay, now remember, going back to this other graph, once again, that what we're talking about here is, in my immediate comparison, is the United States relative to a bunch of European countries and Japan, right, and Australia. So if the United States is falling behind on these measures, we might think, well, okay, what's different about the United States and these countries? Probably a lot of you are thinking in the back of your mind, well, obesity, right? Obesity is much worse in the United States than it is in these countries. You might also be thinking about something like smoking. Of course, we associate the French with cigarettes immediately in our mind, but actually Americans are big consumers of cigarettes. And we're talking about women. Japanese men smoke like fishes, but Japanese women do not, and we're making comparisons for females here. So what we're looking at here is the change in smoking rates over 3 time frames. And remember, we're using this really unique framework, right? We're looking at comparisons between 1975 and 2005, right? And we saw that the United States is just falling further and further and further behind in terms of survival, right? So for smoking to explain the United States falling further and further and further behind over time, we would have to see an increase in smoking in the United States relative to those other countries we're comparing ourselves to, right? So what this bubble graph shows is anything above this 0% line means that smoking rates are increasing. Anything below means they're decreasing. And this little white bubble here is the United States. We're seeing that amongst all of these countries that we're looking at here in our comparison, that actually smoking is declining more rapidly in the United States than these other countries. And as it turns out, the baseline prevalence of smoking was not amongst the highest. So Americans are not more likely to smoke on average than Europeans. However, one thing about Americans that does stand out is they smoke more cigarettes, right? So, you know, if you're French, you lived in France. What the French do is they, you know, you have a cigarette, you eat dinner, you have a glass of wine, you have a cigarette. Americans are kind of like always smoking, cigarette after cigarette after cigarette. So we actually consume many more cigarettes than any other nation in the world on a per capita basis, but there are fewer Americans that smoke. Regardless, the prevalence of smoking in the United States is dropping faster than it is in any other country. So we cannot attribute this falling back in life expectancy to smoking. Okay, what about obesity? That was on all of your minds too. In 1975, it turns out Americans were bigger than anybody else in the world. But over the period 1975 to 1985, we were amongst the bottom nations in terms of increases in obesity. In the 1985 to 1995 period, again, we're in the bottom in terms of increases in obesity rates. And in 1995 to 2005, we're again towards the bottom in terms of increases in obesity rates. So even though we started off heavier, other countries are gaining weight much more rapidly, right? So obesity cannot account for the United States falling behind. Well, what's going on? I mean, when we think of these other countries, we think of people walking around carrying baguettes, right? We think of beautiful buildings. We think of nice communities. We think of social cohesion. We think of social welfare states. We think of all of these different things that could be potentially explaining these differences in life expectancy, right? So let's take a quick peek at what does potentially matter in terms of population health. This is a study I did in 2009, and basically what I did was we looked at the risk factors that we could look at. There were social and traditional sort of medical risk factors for bad health outcomes, and our objective here was to rank them, to figure out like, okay, well, what is it that's really making Americans healthy or unhealthy? And what we see here is up here towards the top is health insurance. Being uninsured versus being insured, it has actually relatively small impact. So we're talking about, you know, like a 300,000 years of perfect health lost due to not having health insurance. Now, this measure is a little bit funny. You can think of it in terms of years of life lost, but it's a measure that combines health and mortality. It's called a quality adjusted life year. Don't worry about that. Just think about it in terms of years of life lost. So health insurance is actually not a big driver of population health. In fact, you know, those 300,000 years distributed across all, you know, 300 million Americans is a tiny fraction of a year per American. It's not our insurance problem, which is a big problem. It's not to be belittled. It's a huge economic problem. The uninsured go bankrupt because they have no health insurance, but it's not necessarily a health problem. Being overweight, just as small. Binge drinking. How many people over the last weekend had more than 5 drinks? That's considered a binge drink. Binge drinking, Also pretty small in terms of the overall impact on health in the United States. This measure, non-Hispanic Black, is actually a measure of racism. This is after controlling for income and educational attainment. And what we're looking at here is, what sort of social deprivations your average non-Hispanic Black faces and what that does to their life expectancy. Here we have obesity. And we see that obesity is starting to become more of an issue than these other factors. So obesity here, we're talking about 100, here's 100 million years of perfect health loss. So this is 100 and 500,000, 100, whatever. The point between 100 and 200 million, 150 million, 150 million. Yeah, I'm right off the plane, folks. Years of perfect health loss to obesity. This is going to start to take a bit of a chunk out of life expectancy, about 6 months on average. So if we got rid of all obesity in the United States, assuming that obesity is actually causing health problems, which we're not even 100% sure of, but assuming that it is, and we got rid of all obesity in the United States, we would be gaining about 6 months in life expectancy, right? Okay, what about high school dropouts? When you think of Belgium or Sweden or Japan, you don't think about high school dropouts. They're doing much, much, much better in education than we are. Education can have a huge impact on health. Just the cognitive impact of education alone can have a dramatic effect on health over your life course. And it's not super intuitive to think about, but it actually turns out that people who are high school dropouts are much more likely to get into accidents, to be able to sort of cognitively evaluate their risk framework. Education is a tool that we use to survive within complex ecological niches, right? So the society we live in is incredibly complex, and to navigate that, you need to have some cognitive ability. But education also does other things for us that are health preserving, right? It gets us a job that will give us health insurance. We get that little bit. It gives us a social network that's much less likely to drink or smoke. So it's going to reduce our risk factors for here and there. Educated people tend to be thinner. So there's that. It's a whole host of it's a measure of a whole host of social risk factors that, that potentially contribute to poor health outcomes. Here's current smoking. Smoking is a huge, 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 huge social problem, but it's not as big of a problem as poverty. So let's stop and think about poverty for a second. You know, when you're thinking about these other countries in Europe, you think about egalitarianism, right? Deep taxation systems. Poverty in the United States does not mean that you're, severely materially deprived, but it does mean that you don't have the resources to live in a safe neighborhood or a safe house. You don't necessarily have access to high quality foods. Poor neighborhoods tend to have high fat, fast foods. People consume that kind of stuff. It's like education, it's a whole host of things that amount to material deprivations and psychosocial deprivations. So it actually turns out that poor people are less likely to have buffers for stress. And stress, for reasons that I'm not going to go in, I just don't have time to go into it, but stress is considered a major risk factor for poor health outcomes. Okay, so poverty, we've got a lot of things going on. Stress is probably one of them. All of these things are just sort of selected random risk factors from a list of things that you could potentially come up with. If we could actually add stress to this column, maybe it would come out to be a bigger problem than poverty, but this is all that we could actually study and look at in terms of social risk factors. So at this point in my talk, I'm going to start to get a little bit mushy and less facty. And we're going to start to hypothesize a little bit about some of the stuff that's going on here. Now, if you think about the social network of people who are poor, they tend to have fewer social connections, right? And they also tend to be in social networks where people are more likely to drink, more likely to smoke, more likely to have other risk factors. The people within your social network, their behaviors are going to be primary determinants of your own behavior. We do things because the people around us do things. The people that we respect and love are the people we emulate. So if people around us quit smoking, we're much more likely to quit smoking. And the sort of leader in this area of research is Nick Christakis at Harvard University, who actually looks at the effect of changes in behaviors within social networks over time. So let's first take a quick peek at what happened to smoking over a long period of time in one particular social network in Boston, the Framingham Heart Study.
This animation captures the years from 1971 to 2003, a period during which Americans quit smoking in large numbers, represented here by the number of gray dots declining over time. The animation also represents how smoking cessation may spread given the influence that people appear to have on each other's behavior within a complex and evolving network of social relationships. During the 1990s, entire clusters of smokers within the network appear to quit in concert, and groups of adjoining nodes are seen to become white. Quantitative analyses demonstrate a tendency for smokers and non-smokers to form clusters within the network, and for smokers to move progressively to the periphery of the network, so that by the end of the study, the prevalence of smoking appears higher at the periphery of the network than at the center.
Okay, so here, again, just to reinforce, the dark nodes were smokers and the white nodes were non-smokers, and you see that the more people that quit within your social network, the more likely you are to quit within your social network over time. And one of the thoughts here is that, okay, well, there are people that are sort of like alpha, right? They're the alpha people, the people you emulate. These are the people that, you know, in the Williamsburgian hipsters that can get people to ride fixed gears bicycles without brakes all over the world. I was just in Bangkok, and there are people riding fixed gears bicycles without brakes in Bangkok. There are people in Beijing doing it. There are people in Shanghai doing it. These are the thought leaders that change behavior within local networks, and then those behaviors sort of spread out, they diffuse out throughout society. And this is the whole idea behind social networks driving behavioral change. Now, it's not just things like smoking. It can be anything. Things are contagious. And prevention can be contagious, and bad behaviors can be contagious as well, right? So if Kit Kat has an amazing, are you eating a Kit Kat? No. If Kit Kat has an amazing marketing campaign and they target the hipsters, and the hipsters start eating Kit Kats, then everybody's going to be eating Kit Kats, right? And then if the hipsters are like, Kit Kats are uncool, man, then everybody's going to stop eating Kit Kats. And that's just basically the nature of social networks and social marketing. But it actually turns out that your very body shape and type can be dramatically altered by the changes in the body shape and type of people within your social network. This stuff is very powerful, and the spread of obesity within a network, also Nick Christakis' work, will sort of illustrate this.
Obesity is a multicentric epidemic, with many people influencing one another and forming ties in complex ways. The network gets more compact and dense as more ties appear, and the entire network gets heavier over time. Quantitative analyses demonstrate a tendency for obese people and non-obese people to form clusters within the network, so that by the end of the study, this clustering can be discerned as in the densely interconnected clusters of obese persons here and here, and the
Okay, fine. Fine. So far, what have I showed? What have I told you? I've told you that that the health of Americans is sort of getting worse over time, and that it's not getting worse over time because of obesity or smoking or other sort of traditional risk factors that we've thought of. I've pointed to a list of other alternative explanations that sort of stand out when you think about the difference between, say, the United States and France, or the United States and Sweden. You think about income inequalities and things like that. You also think about strong social cohesion, right? So you think about countries that that want to lift up all boats evenly, even if some people have to pay a heavy penalty for it. You tend to think of, when we think about Sweden, the CEO of IKEA could be living next door to somebody on welfare, and you wouldn't be able to tell the difference because they're both driving the same car, they have the same house. It's like uber egalitarian, right? The United States is structured in a very, very different way socially. And one possible hypothesis is that it's this difference in structure that's driving health, and these differences in structure manifest through social networks to change the health of all Americans. Mushy stuff, but we'll come back to this in a second. To sort of make my point, I want to show you an image that I rode the train by every day when I was a medical resident. This is a neighborhood in the Bronx, just a poor neighborhood. Obviously, a lot of these houses are sort of burned out, but there's still lots of people walking around and on the streets and living in these places. It's not pretty to look at. It's kind of stressful to look at, right? It's kind of just looking at it makes you stressed out. There's crime in this neighborhood. The housing quality is obviously quite low. There are all sorts of dangers. People burn to death. The mortality rate was very, very, very high in the Bronx, especially in the 1990s. Now it's starting to gentrify a little bit. Here's a series of pictures that I'm just going to go through really quickly from a photographer who does time-lapse photography of the same neighborhoods in the same areas, the same buildings. And so this is the Bronx in the 1970s. You can see you probably don't want this guy living in your front of your building. You can see that it's a low-income neighborhood. And there's something very insidious about the psychology of this neighborhood. It is, like I said, stressful just to look at. And that stress manifests itself in a lot of different ways. One is that you just these neighborhoods have a sort of tendency towards disorder and disrepair. So here it is 10 years later. You can see that the guy is gone. There's somebody else there. And the building is now burned out. But there's rubble all over the sidewalk, but there's still lots of people living there. And then here we have 10 years later, the building is completely gone, and some of the other buildings on the block are now abandoned. So you just get the sense of a prevailing sense of despair and stress, and that probably has a strong impact on our psyche. It's very, very, very difficult to live in that environment. And I would argue, and there's actually good animal evidence to argue, that this stuff gets basically somaticized, that when we're stressed, it disrupts the basic core functioning of all of our body's regulatory systems. We release cortisones that disrupt our immunological functioning. We release adrenaline that disrupts our ability to regulate blood pressure. We can talk about this in the question and answer session. But your environment is potentially internalized within your body. Now, let's think about a public policy solution to this. Imagine that we planted a garden there. Here's a garden that I just came from in Hangzhou in China. This is Xihu, and it's 30 square miles of this, like basically willow trees and violets and water and little stone bridges and lakes. When we think about this, it's just relaxing. Why do we like this stuff so much? You know, humans evolved in nature. We enjoy nature. There's something about the aesthetics of this that's relaxing to us. If we have parks, what do we do in parks? We walk around, we feel very tranquil, relaxed, we socialize, we exercise in parks. We go to parks to jog around rather than jogging next to the highway because it's just much more pleasant to do so. And this is the kind of thing that encourages healthy behaviors. You probably see that I'm probably going to get back to social networks with this stuff and a grand scheme for social engineering. Now, not every neighborhood is obviously as bad as the Bronx. In fact, most of America looks like this, right? This is something that we see all the time. It's everywhere. The whole country looks like this, almost. Like this is this whole sort of weird, sprawling mass of weirdness all throughout, like from the Atlantic to the Pacific. And this is what our country looks like. And this is actually not that much more pleasant, at least for me, to look at than the Bronx, like with its burned out buildings and everything else. But it's also not an environment that's conducive to doing things like exercising. This is an environment, this is a car culture representation. You know, you get from your couch and you get in your car and you drive to the bank, and the bank is really far, and then you have to drive to the next store down there, and that's really far. And each time, you know, you have to deal with people in traffic, and nothing is pretty. So, you know, we could throw in, as a public policy measure, a light rail system, right? So we throw in a light rail system, and now people have to get out of their house and walk down to the train and take the train down here. Maybe this is a good public health intervention. Maybe this is a way of thinking about public health policy. We need light rail to get people out there and exercise. This is also going to be a major drag, right? Because your bank is here. It's taken you like a half an hour to get to the bank. And, you know, and the next door is down there, and it's going to take you half an hour to get back to the next door because nobody's using this light rail system and whatever. But at least maybe if we put in some trees, it'll be a little bit nicer. It won't be like a hot walk in the sun. You know, things are a little bit prettier. Things are a little bit more relaxing. I don't know if this satisfies many people. Another thing we could do is rezone this area so that we can no longer have urban sprawl, right? So now we're talking about low-rise apartment complex with storefronts, and all of a sudden this starts to look a little bit more comfy and cozy. This changes the way that we view the community in which we live. This is a community in which people are much more likely to walk from store to store. It's also probably a community in which people are going to be more likely to socialize in, right? You're more likely to sort of meet your neighbor and to talk. And it turns out that the more friends that you have, the longer your life expectancy, because this is a huge buffer for stress. And we're social animals, and socialization is good for us. There's one thing that's sort of missing in this rendering, and that is this. Whoops. It's not that. It's not that either. It's not that either. It's this, which is a bike path. Now, this is a very controversial bike path that just went into Park Slope in Brooklyn, and everybody hated it because they thought it was going to take away a traffic lane and potentially disrupt parking space, and then you have bicyclists around that are a nuisance. But actually, the before and after evaluation showed that it reduced traffic speeding by 75%, and it increased the number of bicycles in this area from 349 to over 1,000 in a 3-month period per day. And before this bike path went in, about half of all those 349 bicyclists were on the sidewalk. Now only 3% of them are. So it's led to some basic improvements in the way that people interact with their environment. But I would argue that this actually has a much more profound effect on this community than could be possibly measured by bicycle traffic. You know, these people are doing something that's less polluting and is going to be improving their health, but it's also having a much larger impact on the whole neighborhood. And that is that it's normalizing this concept. It's normalizing the idea that we should be exercising, that we should be commuting from point A to point B. People are very, very susceptible to these messages. And you can't tell them, hey, go out and exercise. You have to make it normal to do so. And you have to make it normal to do so without saying anything. People will brag about riding their bicycle in the same way that teenagers brag about drinking so much that they puked, or or the Williamsburgian hipster bragging about having crashed into the back of, sorry guys, I know you're Williamsburgian, crashing into the back of a car without brakes because they didn't have brakes on their fixie bicycles and they were still getting used to it or whatever. People will adapt to healthy things in cool ways the same way they will adapt to harmful or unhealthy things in cool ways. What's important is that it's cool. That's all that's important. So can the city make people exercise more by running a clever advertising campaign? Maybe. It could help or it could hurt. But by doing these little things that nudge you, you can more effectively change behavior. Now, I started off by saying the United States, okay, health is getting worse than these other countries, right? And I then said that obesity and smoking were not probably the main drivers of this, but it probably had to do something more with the way that these other societies were structured, right? And that this structure was probably, over time, improving the health of these other European comparison countries relative to the United States. Right? So the United States was probably getting more sprawly, and these countries were probably getting more developed in terms of, more sophisticated in terms of implementing more metro systems and more high-speed rail. And they have better schooling, and the schooling outcomes have been getting better over time, whereas in the United States they've been staying the same or getting worse. And that could be explaining why the United States is falling behind. I also sort of showed you some social network stuff that showed that thoughts and ideas spread through social networks, right? And I then provided an alternative framework for sort of modifying the US and the lifestyles that we lead in subtle ways, policies that change the aesthetics of our neighborhood, policies that nudge people into doing things that are healthy for them, and normalizing behaviors that are healthy, right? The ideal is not to tell people that they should be drinking lots of water, but to make it cool to carry around a water bottle, right? We associate that with yoga, right? It's cool to carry around a yoga mat. People are going to think you're doing yoga, even if you don't. You can walk around and carry your yoga mat. So we want that to be the norm. And these norms will spread within the social network. So there's some sort of interaction between the things we do in public policy and the way that people behave within the neighborhoods that are affected by those public policies. That's the overall gestalt of everything that I'm saying. But I also said one other thing. And that was, this stuff is fluffy, right? We have no data behind this. We do have some data. We even have some animal models and this and that. But we don't have rock solid data that we can take to a policymaker and say, look, if you put in this bike lane or you put in this public transit or you rezone this neighborhood, that you're going to get healthier Americans out of it. Right? So how do we get there? Well, this is where Googlers come in. And the only way that we can really get there is through the gold standard of scientific research. And the gold standard of scientific research is something called a randomized controlled trial. And the idea behind a randomized controlled trial is you basically take a group of people, they all agree to be in the study, and you randomly assign some of them to receive an intervention you're doing, and randomly assign others to be in a control group, right? Did you hear somebody? Are we out of time? Okay. You could, yeah. And if we have that kind of data, then we can be 100% assured, or nearly 100% assured, that whatever it is that we're observing is true. Now, one way of doing this with neighborhoods, obviously we can't just randomly assign people to live in a neighborhood that's been improved and a neighborhood that hasn't been improved. But we can randomly assign, say that we were using Google as a giant laboratory, Google employees. And we randomly assigned.
Hi, on BC, if you could mute your mic. I think you guys might accidentally be on our bridge. Hello. Hi. Could you mute your mic?
You get it? There we go. They just cut their whole video feed. So what we can do is, like, say that Google was a giant laboratory and we had all of Google employees to do this. And Google employees live everywhere in the world. They live in some communities. Now we've got no video, but we have an audio feed. Googlers live in some communities that look like the first one with the big straight street, plain, urban sprawl area. Some people live near parks. Some people live near small residential areas. If we randomly assign folks a education, exercise promoting intervention, and then looked at how it distributed throughout the Google network, like, did people that live near parks start to exercise more, and people that didn't live near parks not uptake it? Did people who were randomly assigned the exercise intervention who lived near a park exercise more, and then spread the information to another Googler who lived near another park, and then they exercise more? Then we would actually be able to come up with an overall model demonstrating that living near a park is actually going to increase your chances of exercising. For example, you can do this with anything. You can do it with food. You can do it with a diabetes program. You can do it with anything. But we want to show ultimately that that your neighborhood has a huge impact on your psyche, and that psychological mindset in turn affects your internal health state. So this is the information that we would ultimately need to get to the point where we can go to policymakers and say, look, we need to change the way that we are structuring our society, and we need to start nudging people towards healthier behaviors. But we also need to create neighborhoods that are safer, more aesthetic, have better modes of transit, and so forth. So that's my talk for the day. Do we have questions? Yes. Oh, man, I wish I knew the answer to that question. Like, why is it that Europeans don't sprawl and we do? I mean, I guess we have a lot of space, but it must also just be cultural. I mean, usually communities that have some awareness about this will put laws on the books saying that you can't sprawl, like, this is the city limit. You can't build beyond that point. This is agricultural zones. I just came back from China. They have those laws on the books. They get very upset when builders build in areas that are zoned for farming, because they want the cities to be very dense and high, so that the public transit systems that they're building everywhere actually reach everybody in the city. It's the most logical thing to do, but for some reason, historically, it just hasn't existed in the United States. Mm. Yeah. So the comment was, because they can't hear in the other room. The comment was like, it's that American drive for independence. You know, like we have a car culture, and we want to have our private house with our wife and 2.5 kids and the car, and we want to live our lives that way, and we have the right to live our lives that way. Whereas in other countries, there's more of this notion of like, well, we're all in this society together, and there's a sense of solidarity. And if you're going to go someplace, you might all pile into one car and go there as one big, happy, non-family. Any other questions or comments?
And also in some areas like underscore little health, and we have it's not like Mountain View with bike lanes. We do have bike lanes. Big high rise, so we have what we see there.
Yeah, well, we were actually just talking about this a little bit. So, obviously, actually, I think that Google is doing that here, and that the long-term plans of actually putting in bike lanes on campus is a great idea as a start. But in an intermediate, and as a sort of intermediate step, I'll get to Chelsea in a second, but as an intermediate step, one of the things that needs to happen both here and probably also in New York is that Google should play its role as a citizen of the community in which it lives and advocate at the community council level, especially at the community council level, at the county level, to improve the existing city infrastructure, because a company the size of Google has a huge impact on policy making, because the community wants you here. And you can say, we want the community to be better, and we want it to be better in these ways, and you can do that. Within the context of Chelsea, it's a little bit more difficult in some ways, but in other ways it's a little bit easier, because New York City has already bought and sold on the idea of improving their communities, and New York City has a interdepartmental collaborative framework where the Department of Health and the Department of Transportation and the Department of Sanitation and Environmental Protection, they all work together to meet objectives like improving health. And they have to fight against community boards. So if Google can go to the community board and say, hey, look, we're one of the biggest players in your community, and our employees really want bike lanes going into and out of the company, then you can get that. You already have some, but there needs to be more, and they need to be more extensive, so that employees who live, say, in Central Park can have a protected bike lane to get all the way down to their work, for example. So that's a start. I mean, it's very difficult to get out of an enclosed space. The question then becomes, well, what can you do once you are out of that enclosed space? Getting to and from work outside is going to have a huge potential positive impact on the psyche of the employees if they can bike to work rather than go underground, take the subway, come back up, go up into their office and be inside all day. So advocacy for greater public infrastructure would be one recommendation. Any others? Oh. Yeah. Right. But you can actually build parks. So that's the whole idea, is that with the health departments, they're just so underfunded, but they can work with parks departments and with city councils and mayors and governors to advocate for more green space. And you can put parks in the most bizarre, like a park doesn't have to be any particular geometric shape. You can put parks in all sorts of different areas, abandoned lots and things like that. Like the Highline Park, yeah. So this is a prime example. The Highline was just an old elevated freight railroad in New York City that had been sitting there rusting forever, and the city basically said, well, let's turn that into a park and put put a very beautiful park space going along the whole top of the Great Line. Yeah, it's pretty awesome. Google it. Yeah, it's just near Google. Okay, thanks everybody.